I definitely want to thank both of you for very moving discussions, difficult for you, but informative for us all. Martin, I want to say you are a true artist, and we appreciate your comments today. And Jennifer, your articulate discussion, which is also very difficult, and the need for communication, patient and family engagement, has been really presented in such an articulate manner that we appreciate the learning that we're going to get from that. Just a quick story, and I may have mentioned this before to the roundtable, but on personal experience, and there are others in the audience who I've worked with for multiple years on the clinical side, will, I'm sure, substantiate the need for communication and the development of trust that communication, adequate communication, engenders. But I always remember from my clinical experiences what I refer to as the hand on the doorknob syndrome. I don't know if anybody has heard me say that before, but after spending half hour, 40 minutes or so with a patient, going through the clinical details, physical examination and discussion, and any other questions, patient gets up and doesn't exactly leave the room. The hand remains on the doorknob for just a few moments. And if you notice that and ask the patient to come back again and say, you know, is there something I missed or something you want to say? You then find out the true reason for the patient's visit, which perhaps you missed in the 45 minutes previously. So that hand on the doorknob, the ability to communicate is something that becomes innate for people who want to learn the methods of communication. So I think you brought that to the table this morning. We thank you. Okay, let's open up to questions from the round table, and we'll begin with that, or comments, and we'll then go to the audience outside the round table. So if you have a question, please step to the microphone, identify yourself, and we'll go from there.
Hi, I'm Katina O'Leary from Health Literacy Media. Excuse my voice, I've got a little cold. Those are really terrific talks, both of them. I really appreciate you coming here, and I can't imagine how hard it is to stand up in front of lots of people that you know and trust and like. And
Katina, can you use that microphone?
I don't know.
You have to be close.
Okay. Really close, so
there
the rest
of
you don't get close. Because
there you
go. My official mic today. Back to telling you how awesome you are. Thank you. It was really nice to hear both of your perspectives, and you know, you said some of the similar things, but with a different approach, and it was really helpful. But Jennifer, we've talked a lot about your work in health literacy, and you seem to address two different kinds of issues. One is there's some system-wide issues of using the systems to the best of their potential, and I think we all understand from a business perspective that somebody behind the curtain will make decisions about that, and it's wonderful that you made those recommendations. But there are some other communication suggestions that you had, and I'd like to hear you say more about how do you think we get to the point, what do we do to help providers not... We've done a lot of trainings. What do we do to help stop these kinds of thoughtless communications that you had, the lazy communications? How do we get better than just sort of the work that we've been doing for 20 years? Ideas?
Well, one of the things I noticed in trying to innovate in the health system, which I got to this particular health system, there was no health literacy role there at all. So I think Audrey came up with this. I agitated for a couple of years, and then this system created the very first health literacy role. It was 24 hospitals, 50,000 employees, 5,000 physicians, and me, one health literacy person. That was a triumph to have that. And what I noticed in innovating was all the providers were on board, but just don't change my workflow. And when you look at how they are incentivized and what they are measured against, they're measured against EHR efficiency and time spent. The electronic health records run healthcare at this point. And that's what they are so focused on, that all of their workflow revolves around that. So I think the patient is an afterthought at some point. And I think if you switch the incentives around, so a provider is actually the number one thing they're being evaluated on is, how well they're communicating with their patients, that would change a lot. But and I feel for these folks. They're spending 6 and 7 hours a night on EHRs when they get home. They're miserable. This is why we have added them to the quadruple aim. So I think that's one of the, add a carrot instead of beating them with the EHR stick. I think that would change an awful lot. It's a simple answer to a bigger question, but.
Stacy?
Thanks. I'm Stacy Rosen from Northwell Health. As a practicing clinician for 30 years, I don't really have a question. I just want to thank you for coming up and speaking to us today. Last week or 2 weeks ago at AAMC, Dr. Berwick spoke about repeal and replace HIPAA, which he said as a joke, of course, but it was, everyone sort of in the audience smiled. Sitting in LaGuardia this morning at 4 o'clock, there are 2 pieces in the New York Times that I'll share the link. One is by Perry Class about taking care of physicians, the pediatrician from Boston, I guess now in New York. And the second was by Danielle Ofri from Bellevue on paperwork versus patients. Literally an hour ago, I was just reading them. It's on the digital New York Times, and spoke quite a bit about the burden, the intricacies of doing right, and how physicians, the vast majority, thank goodness, want to do right, and that the getting doctors and clinicians to just do yoga or sleep better is not enough. And there's been so much discussion about clinician wellness, but it's really so much more than that. So take a look in the Times today.
And on that point, I believe it was Berwick who wrote about the 3 eras of healthcare, and the first is the paternalistic era that we're slowly retiring out, I think, because of the training has moved along. The second is the one we're stuck in now, which measures everything, whether or not maybe it needs to be measured. And the third, to me, swings the pendulum back that he's advocating for towards a more health literate experience. So, yeah, absolutely.
Don Berwick always reminds me of the story. Once again, I've probably told this before, but it's worth repeating. When he spoke at his daughter's graduation from medical school at Yale, and he said, after giving his usual commencement, said, the best thing you could do is take off your white coat and sit amongst those of your patients and others, and you'll really learn what it is to be a physician. So I remember that because that's the way you learn really how to communicate. Andrew.
Thanks, Bernie. Andrew Pleasant, thank you both for your stories. Wish you didn't have them to share, actually. But from a prevention perspective, how would you, I imagine you both thought about this, how would you suggest health and medical education be changed so that what happened to you doesn't happen to anyone else?
I don't know how you teach good communication. You start in kindergarten, and from little on up, we teach people how to communicate with one another. I have a friend in Ireland that I worked with on some projects. She's a mosaic artist, and she says over there where you go to medical school, you have to take a personality test. And one brilliant young boy didn't pass the personality test. And the next day his mother came to the academics and demanded and raised hell and hit on the table and said, "Why is my son, he's a brilliant student?" And they said, "We're afraid he will act like you."
That's great. I think I have two answers to that. The first is having medical schools pay attention to Dr. Cliff Coleman's work. And the second is, when I was a writer, I worked in PR and marketing when I was first graduated from college, and going to these doctors and didn't understand what they were telling me. And I was taught, you don't question doctors. I was raised in a working class family that, very deferential. And I realized, though, these people are so smart, but they're not good communicators. And I sort of accepted that because I thought, I don't want my doctor to be a great English major. I want him to be a science nerd, and that's okay. But then I realized this could kill me, right? Some of these challenges. So I agree. I think just recognizing that communication is part of the job, and if you're not good at that, then go into radiology. And I don't mean intervention radiology where you're talking to patients, but I have best friend's brother's a radiologist. He says he can't stand patients, and he's helping people, but he's doing it behind a computer screen. So this is part of the job. It is unacceptable. If I was a terrible communicator, I would have no clients. Why do we accept that?
It's the only industry where we do. I've worked for farmers, bishops, sports figures, well-to-do, average Joes, and a lot of doctors. And I've gotten along just fine with all of them. I've had no trouble communicating to them where they wanted their drawers and how they wanted their pencils to fit in the drawers. I got along just fine. But I spent a lot of time asking them and finding out what it is they liked. Even to build somebody a rocking chair who intends to use it to nurse a baby. It calls for a little different arm design than somebody who just wants to sit back and rock and read the paper. But you have to be able to communicate all these little issues with people. Sometimes that's the best part of the job.
Well, you'd be curious about you're saying your story, you were what we would call patient-centered, client-centered. You were trying to
Yes, customer-centered. Patient's a customer. Isn't that right?
Person-centered. Person-centered. Cindy.
Hi, I'm Cindy Brock with the Agency for Healthcare Research and Quality. And because today's theme is about building the case for health literacy, and both of you have touched upon sort of the business side proposition of healthcare. And Marty, I wanted to ask you to make sure that I'm not doing too much reading between the lines. But when I heard you tell your story about sitting down with the risk manager and people from the hospital and not hearing an apology and that whole interaction, the research that we've done indicates that people are more likely to sue when there are medical errors, when there is that poor communication. And in fact, my agency, ARC, has developed a toolkit called Candor about talking about these things and about being able to say, I'm sorry, with feeling, and to process and learn from mistakes. So my question for you, because not every health institution has adopted these kind of techniques, is what kind of difference would that have made for you? And in particular, do you think it would have made you less likely to sue the institution?
the day I asked for the apology, and several times before that, if there could have been an apology, we could have started down a totally different road. And Sorrel King, I don't know if you've read Josie's story, but the people from Johns Hopkins came to their home and apologized. And there's a Dr. Fred Southwick. I don't know if anybody in here is familiar with Fred Southwick. He's a physician, and he's had his leg amputated twice because of a medical error. And he also believes that if there's an apology, we can go a totally different road. And I would have been, and I've had doctors that I know as friends who've said I would have been the model for a different way of dealing with this series of mistakes. But there was a constant finger pointing and denial that anybody ever did make a mistake. So how do you correct mistakes when people say, I didn't make a mistake, you know? If the door is hung upside down, somebody made a mistake, you know? And it's clear as a bell to me, and I'm just, you know, an average guy. It took me a while. I had to go get my medical records, and they were reluctant to give them to me. I paid them $100 to copy my medical records. It was definitely a barrier that was put up to discourage me from having those records. But, you know, I sussed it out, and I thought, there's been a lot of bumbles here. And right when I was diagnosed, that very weekend, I called my primary care doc, and I says, you've been telling me I had a hemorrhoid. I have cancer. And the response on the phone was, well, I was focusing on your diabetes. I'm not a diabetic.
Oh.
And if I could just push you a little bit, though, because I think one of the themes that I heard from Jennifer is that there's a certain dollars and cents mentality that that because healthcare providers are also businesses, that in order for them to make changes, there needs to be some financial incentive, or at least an ability to make the case to do what they know is the right thing. Do you feel like you would, I'm bringing it back to the lawsuit aspect, because I know that's something that most clinicians and institutions fear a lot. Do you feel as if a lawsuit could have been averted, could have been prevented if they had taken a better communications approach?
I think it would have been better for everybody.
Okay, thanks.
Suzanne?
Hi, I'm Sue Bakken, and I'm a nurse and also a biomedical informatician. So I guess one of the things I would first apologize for is the failure of my field to yet come up with an informatics solution that truly is more patient-centered. And we know that our current situation certainly makes it very difficult for both the patients and the providers. But my question is, I was wondering if either of you had any experience with the open notes movement that's currently going on at places including the institution, the clinical institution that we're affiliated with, and also if you are familiar with it, what you think in terms of possibly some of its implications for a health literacy agenda.
You go ahead.
Okay.
Yeah.
I'm familiar with it just from working in healthcare systems. The one I was most recently employed by did not have it or hadn't adopted it. I'm all for anything that allows records to be more portable. One of the greatest frustrations from a patient side is that, you know, you've got these electronic health records and you have the patient portal, but you can't put anything in the patient portal and have it feed back in, because I cannot be trusted to provide information to my own medical record. Not even as simple as I got my flu shot at Safeway. So the system keeps telling me I'm due for my flu shot, but because I didn't get it at the system, I got it at my grocery store. It's not in there. So I think anything that circumvents these nervous Nelly health systems and their data integrity issues is a positive. I do want to say, you know, I said some frank things about Epic, and I think we have to remember our electronic health records are built as their billing platforms, right? And every health system in the country is trying to essentially put lipstick on a pig and turn these EHRs into patient engagement tools, and that's not what they're built for. So back to you and your field, I think there's huge opportunity to add on sort of proprietary products or these open source type products to help fill that gap.
Yes, I mean, it is a very difficult time for the field because many of us work in institutions where there were homegrown systems, and now we have that had increased functionality, and now for business reasons, people are basically, hospitals are tending to have one of two systems, right. Which in almost all instances results in some decreased functionality. Right. Marty, did you have any experience with having the electronic open notes? I know it's been...
You're talking to the wrong guy when it comes to electronic medical records and computers. Right. I never touch them, and I don't know anything about it. So I know about personal relationships, when we went to Siteman Cancer Center in St. Louis, my wife called a friend, and then she called a colleague who called somebody, and we went up to St. Louis and walked into Siteman Cancer Center, and I said, I got cancer and I'm here to see Dr. James Fleshman. They say he's the guy to see. It was just, I mean, it's pretty homegrown, but that's where at the beginning, and he sent me to Missouri Cancer Associates, and Dr. Peters, a colleague of his who was my surgeon, and it was all word of mouth. It was exactly the same way I work with my customers. You know, I never advertised, and it was all just because basically it was just sheer luck, you know, that we got the care that I got when I was desperately in need of it. And you know, when you go back to when I had my very first colonoscopy, the CEO of the hospital where my wife was working was a GI doctor. And when she went in and said, my husband's had this polyp removed, they told him it had cancer cells in it. If he would have just, instead of saying, he's in capable hands here, if he'd have said, he needs to be followed every year. And I think that when just come down one step, one notch, you know, that's all, because when we heard I'm in capable hands, I thought this is a green light, you know, and I had no idea there could be a reoccurrence. I thought once something's removed, it's removed, you know. But you know, you learn all this, you learn everything the hard way, don't you?
One thing I want to add too is the sheer luck that you had. Your wife knew someone who knew someone.
Yeah.
I come from a family, we don't have any medical professionals. I constitute a medical professional in my family because of my work, which is pathetic. I don't have an uncle I can call or an aunt who's a nurse. We don't. So how do we have a health system that works for folks who aren't lucky like that? It needs to be democratized. And I'm thrilled. I mean, you might not be sitting here if it weren't for that. But care by accident, we can do better than that. We need to do better than that.
And it would only make sense that somebody would say, well, you have a hemorrhoid. Even the first mistake, because I thought, well, yeah, I do a lot of lifting. I've done a lot of lifting my whole life. And I worked with old carpenters when I was 21 years old, and they'd say, my hemorrhoids are bothering me. It's from all this lifting. So it only made sense to trust not only the doctor, but the diagnosis. And I kept thinking, okay, I guess, who am I, you know?
Thank you so much.
Wilma?
Ernestine Willis at the Medical College of Wisconsin. I am I thank both of you for letting us as physicians see a mirror of our system and the errors and the consequences of what can happen with these errors. But I was wondering, Marty, you made it very clear, a pivotal time in your condition, your wife was your strongest advocate and you gave her credit. And I was wondering in Jennifer, your practice or your system, I do agree with Marty's point, and I've had some personal experience that say, even as a physician, I've had to have an advocate who could hear things that I could not hear because of the trauma that I was going through. So I'm just concerned about how has your systems, Jennifer, been able to incorporate advocacy for patients in that crucial time of deliberation where you just miss some of the finer points that's critical for you to make good medical decisions?
You know, to be clear, I left the system in January to start my own consulting practice, so I'm not there currently, and I can't speak to what has happened this year. Before I left, there was no formal effort beyond encouraging folks to bring people. I think that's why I have worked very hard since before leaving, and have continued this work since to work on that after visit summary, because for those of us who can't bring someone with us, it is the only record of what you may have missed. And obviously the gold standard is to have someone else there with you, but I think that you read the meaningful use requirements, and that's what it was meant to be, and that's a health literacy intervention. You know, you're hearing it, I've got an auditory experience, now I have a written experience, but what gets put in there is useless. People aren't reading them. So I think that's an area where our field can really affect some change. And I'll be honest, the electronic health records, I fought very, very hard to get some stoplight tools I'd written in. Epic said, you're the only system asking for this. We have to wait until we have other customers asking too. And so I think we can exert some pressure there as a profession.
Wilma?
Wilma Alvarado Little, New York State Department of Health. Marty and Jennifer, thank you so much for your stories. Marty, what struck me, and please correct me if I've misunderstood, that the response to the question, or the comment, he's in good hands, was at a moment when that came from the organization from where your wife had been working, yes? Okay. And so I think sometimes, Jennifer saying that she's a healthcare person in her family, I think sometimes when we are employed, for example, within a healthcare system, there's this illusion that we have inside info, right? Mm-hmm. Or that our employer is going to treat us like family, right? And to which some people might say, oh, that bad. So I really appreciate that lens, because sometimes because we are involved within a healthcare system doesn't mean that we as individuals are going to be getting honest responses. And I think that was really key in what you were saying. If this is a response that they're giving to somebody within that healthcare employment family, what else is being said out there? And so I thank you for bringing up that perspective.
Cindy, my blog partner.
Sorry for double dipping here, but I just wanted to confirm Jennifer's take on the after visit summary. And for those who were not with us then, we've actually held, the roundtable have held a workshop on the after visit summary and trying to improve that. One of the speakers at that workshop, Alex Fetterman from Mount Sinai in New York, went on to get a grant from ARC, from my agency, and did some research which has been written up and hopefully will be published soon. And one of the things that after they went out and they did a lot of qualitative work with patients about what they want to see and clinicians and et cetera, what they found talking to other people around the country as well as their own experience of trying to make a more understandable, more actionable after visit summary was that there were very few degrees of freedom in the electronic health record platform to be able to do that. And what was more, well, maybe I shouldn't go further on that, but that you've really sort of put your finger on what is a endemic problem, not just in the one institution. So thank you.
Ms. Ratterman, I think, Marty, that's the woman you referred to consistently during your talk.
I am the wife.
Yeah.
So here is the thing, addressing your issue. I'm Gwen Rodderman. I am Marty's wife. And I've been in health literacy a long time. But to the question about accessing medical records or the OneNotes, if you watched his face, he didn't even know what you were talking about. My husband is computer illiterate, and he's not afraid to say it. But so is my mother, and she's 87 years old. And in fact, when she gets that information about how she can access her medical record, she trashes it. She doesn't even want me getting into it. And I'm her power of attorney. So all of that stuff means nothing for the people who are costing our healthcare systems, the bulk of the cost in our country. And so we really, really need to think differently again, or maybe go back to the way it used to be in terms of, as Marty says, about communication. Because we can't rely on a computer. People can't afford them. They're too old to use them. They don't care. They don't want to use them. And so to base so much of our system on that sort of communication or that means of communication is really not a good way for us to think about the health, communicating in this healthcare system. And that's my comment.
Well, my wound care physician has told me, she says, I never thought the day would come when there'd be a computer between me and my patient. Mm-hmm. Mm-hmm. And she's about 5 years younger than I am.
Hi, good morning, everyone.
Good morning.
Sochan Laltu. I'm from the Caribbean. I actually teach public health. I know it may be a more national-based discussion, but I was worried about, internationally, where we have so many impoverished countries or countries where people are not empowered. Something that bothered me, and I'm not even sure if I should raise it, but I took my mom to a doctor, and we supposed that he was a nephrologist. And what happened was that she was supposed to get the results because the other doctor, that her normal doctor, wanted to see what was the synopsis of the, the diagnosis or whatever it is. And he refused to do it. So I'm a bit concerned, internationally, and especially for developing countries where people may not be as empowered and have that kind of control over access to records. And even sometimes, you feel not even articulate enough to be able to discuss with a doctor your health concerns. So I'm just wondering if there's any movement on an international front for promotion of health literacy. I'm sure WHO is doing something, but anything else would be fine.
I'm probably not the best one to speak to that, but the answer is yes, that there is a growing movement, and sometimes I fantasize about moving to Canada because beyond the healthcare, they're doing an awful lot. We're doing a lot here. I know, I think, is it Christine Sorensen? That's leading, and we have two gentlemen here that are involved in that, so they could probably speak more to it. I think it's a universal problem that you're talking to or speaking to it, just the idea that you don't speak the same language as your provider, and the onus is on the health system to meet the patient where they're at. That's the alignment component, and that's...
I'm going to suggest also that you pick up the proceedings of the workshop we did.
I actually have already.
Okay. Of course,
for my students.
It doesn't
Yeah.
exactly address the issue, but it would be helpful to you for understanding the facilitating health communication in that particular situation.
Yeah, thanks so much for your response. I was just, it's sometimes when I carry my relatives, because I'm articulate and a little more informed about medical terminologies, it's sometimes you get some sort of resistance sometimes because you are being very forward and you are asking very pertinent questions. You understand the physiology or the biology of the medical terms, and it's sometimes a bit of a shock. I don't know.
Mm-hmm.
Thank you.
Yeah,
Thank
absolutely.
you.
Well, we've kept you up here for a long period of time, but it's been certainly worthwhile from our perspective. I want to thank you both for putting together your stories, and I want to thank the audience for the appropriate questions. And once again, it's been a very informative workshop. Thank you.
Thank you. Good to meet you.